So much for inviting me to talk. It's a real privilege to be here. One thing I just wanted to point out before I start is that although you can't record them, we are recording these. So these will be at some point up on the website. So don't worry if you're missing things and you want to see them again, or even tell your friends and other people to go and watch it, or tell your relatives or your employers to go and watch it. So I'm going to try and give a really widespread overview on cluster headache, and I'm aware that there are going to be some parts of this that will possibly be covered a little bit later on, maybe in more detail. We're going to have talks on oxygen, we're going to have talks on advanced therapies. So I'm aware that there may be a little bit of duplication, but I'm going to try and give a sort of a whistle-stop tour, going through the clinical features of cluster headache, and also all the treatments and things. I'm not going to talk about pathophysiology, though, so I don't want to send you to sleep at only 10 o'clock in the morning. So I'm from the Walton Centre in Liverpool. This is Liverpool. These are my disclosures. So I tend to provide a lot of scientific advice to companies. I've been involved in a lot of clinical trials. So these are the four sort of parts that I'm going to talk about: the diagnosis and differential diagnosis. And you'll have to forgive me because I will talk a little bit about other headache disorders, because I think often there's some confusion as to what's cluster headache and what's not cluster headache. And patients with cluster headache will often have parts of other headache disorders as well, and it's worth knowing what's what, because if we can get all the right components, we can treat them appropriately. I'll talk mainly on cluster headache. I'll have a section on current and emerging treatments, and then specific at the end, I'll just say how we do it at the Walton Centre, which doesn't mean it's how everyone should do it, it's just how I think everyone should do it. No, I didn't say that. So I'm going to just start by asking you which of these patients might have cluster headache. And I make no apologies that I give the same lectures, whether I give them to doctors or I give them to patients, because I don't see the difference. I think we should be all singing from the same hymn sheet. So I ask the doctors these, and they often get these wrong, so don't worry if you don't get them right. So I think you're more likely to get them right than other people. So a 36-year man with a constant unilateral headache, but 3 to 5 episodes per week of severe worsening lasting 3 to 6 hours with autonomic disturbance. Second one would be a 24-year lady who's got episodes somewhere between 20 and 120 minutes, but it's a severe bilateral headache. But she gets agitation, restlessness, autonomic disturbance around the nose and eyes, runny eyes, etc. And she's typically woken up every morning at 3 a.m. An 18-year-old lady with attacks of unilateral severe headache on a daily basis, typical one attack every night, associated with red runny eye, and she's got pain on a 10 out of 10 scale that's more than 20. So I think of the 10 out of 10 scale, 10 is your previous imagination, your worst imagination of what a human being could have in the way of pain. So examples, maybe a person who's been hit by a truck at 50 miles an hour lying in the road with all the bones sticking out. Maybe a woman 4 days into her labour about to give birth to a 13-pound baby. Those are my imaginations of the worst pain, other than what you have, and then you put it on your scale. All I want to know from patients is it more than 10? If it's more than 10, then I'm thinking cluster. If it's maybe 9, I'm thinking maybe hemicrania or something else. So this lady, she has the same attacks in the day, but they're typically preceded by up to 15 to 20 minutes of this zigzag kaleidoscope disturbance in her vision. And then the last one is a 46-year man who's never had any pain in the head or face, but he presented 8 years ago with a small pupil and a droopy eye, a Horner syndrome. And now he has episodes of feeling flushed and sweaty. His ear feels full. He gets watering of his left eye, and typically it occurs 4 to 5 times a day. So I want you to just hold those cases in your mind, because they're going to be the focus of what we talk about as to how cluster headache varies between people. These are not typical patients with cluster headache, but I'm going to ask you which of these have cluster headache at the end. So this is my scientific bit here about the incidence of migraine versus hemicrania continua versus cluster headache, and I've tried to sort of do it pictorially. This bit here is tension type headache, and you'll see that there's no head here. It's a tight band-like headache. The reason that I've used this piece of artwork is because I actually am not sure that tension type headache exists. if it does, I think it's vanishingly rare to see a true tension type headache. But we're looking at most of the population having migraine, and this is where one of the problem lies, that if you go in with a headache disorder, it's likely that people are going to think you have migraine because that's what they see every day. So they're not looking for the rarities. Hemicrania continua, I've actually put up quite high here. That probably isn't in keeping with scientific literature, but in my experience, I think a lot of people have a hemicrania continua picture, whether it's the condition that's truly responsive to indomethacin, as says in the textbooks. I think there's a story there that will emerge in the future. I don't think we can define a condition purely by its responsiveness to a drug, even though that's what we do. Cluster headache isn't quite as rare as you think, and you're all here. New daily persistent headache, which is a headache which came on one day and stayed, which can turn out in the end to stay as new daily persistent headache. With treatment, we might see gaps, and we might relabel someone as migraine or cluster headache or something else. For those who haven't heard of the term SUNCT, it's got a useful abbreviation because its name is actually short-lived unilateral neuralgia form headache with conjunctival injection and tearing. And if you have to say that every time someone asks you at a party what your condition is, SUNCT. Paroxysmal hemicrania is very similar to cluster headache, but much briefer attacks and much more frequent. And then that should have said tension type headache, but as I said before, it's probably just a mistake on the slide and it doesn't exist. Don't worry if you can't write all this down. It's going to be on the lectures that are going to be online. But this particular slide should be a go-to slide if you or your friends or other people are wondering if they have cluster headache. And it differentiates tension headache, migraine, hemicrania, cluster headache, paroxysmal hemicrania, and SUNCT. And I don't want you to think about all the little bits on this slide, except to say that as the name gets longer, from cluster headache to paroxysmal hemicrania to that one with a very, very long name, the attacks get shorter and you get many more. So, for instance, you will have SUNCT, you might have 400 attacks a day, but they'll only last a minute or two, or even seconds. Whereas paroxysmal hemicrania, you might have 15, 20 minutes each time, but it might happen 15 times a day. So what are the most important discriminating questions that I ask patients in a headache clinic? And it's not the ones at the bottom, which are what everyone gets asked, which is, do you have sensitivity to noise or light or smell? Do you have nausea or vomiting, or do you have a disturbance before your attack where your vision goes funny or you get funny tingling? That actually doesn't help us. Those ones at the bottom, which are what everyone asks because that's what we were taught at medical school, they happen in everything, pretty much. Whereas actually the ones in black will be the ones that actually we need to know and we need to look at. So what's your behaviour in an attack? What do you actually do? Is it just absolutely on one side, or can it sometimes be on the other side? Can it be on both sides? When do they occur, and how long do they occur for? In cluster headache, I want to know if there's any alcohol that triggers early. That could be really useful. I want to know whether touching, I mean, everyone with headache disorder has the potential to have a tenderness and even a bruised feeling or a burning feeling or anything nasty just on light touch. But does touching actually bring on an attack? Because if it does, that puts you in a different category. If specifically touch, ow, touch, ow, touch, ow, in terms of bringing on an actual attack, then we think of that condition SUNCT or trigeminal neuralgia if it's lower in the face. Then I want to know whether your condition is something that just happens all the time, or do you actually get discrete times of year where for 4 weeks of the year or 8 weeks of the year it floors you? Now, I was asked whether do I really need to have the slides on migraine in here, and I do think I need these because just statistically speaking, you know, at least a fifth of you, if not more, will have migraine in this room, even if you're the patient, not the supporter. And it's important to recognise migraine's not just about attacks, but it's about a whole biology. It's about the way your brain is functioning. And it's going to be there because, unfortunately, you had the parents you had, but they've given you some good things as well, I hope. There's going to be either a few genes or lots of genes, we don't know. If you've just got maybe a little bit of a genetic predisposition, you might not get much migraine. If you've inherited a double hit from both parents and you've got strong genes, you might have been really, you know, quite badly affected. So I would wonder whether everyone actually has a tendency to migraine, but it's just a question of how much we push you. You know, if I put you all on celebrity, well, not celebrity Big Brother, unless if there's anyone famous, let me know. We want some patrons for the society. But if you're not famous and you just go on ordinary Big Brother and you get kept up all night by people talking a load of nonsense, you know, that's enough to push a lot of people into headache where they wouldn't have realised they had migraine before. And I like the comment that I make is that everyone with migraine may wear a migraine hat. In other words, when you get whatever causes your headache, you may get migrainous features to it. So I could come along and hit you on the head with a hammer, and you get a head. If you've got migraine in the background, then your headache will look migrainous. I won't do that, by the way, because I think you're already suffering. Patients with cluster headache or other types of trigeminal and autonomic neuralgia therefore can have aura. They can have sensitivity to noise, light and smell. They can have nausea and vomiting. The three things that happen with migraine, and three things that make you have a migrainous brain, are going to be amplification, autonomic phenomena, which are the sort of automatic nerves that automatically function, things that control your heart rate, your bowels, your flushing, your heat regulation, and brain dysfunction. Are there abnormalities in the actual brain networks where you're going to get these other symptoms? So amplification, everything becomes more, so noise, light, smell, but even sensation, a normal sensation, even in parts outside the brain, can get what we call allodynia, where just touching them actually makes you feel, you know, quite sunburnt or painful. So all these sensitivities will be there through amplification. The autonomic features, the systemic ones, nausea, vomiting, diarrhea, increased passing of urine, going very pale, flushing. And then the cranial ones that we talk about, red, runny, droopy, or puffy, or I think twitchy eyes, stuffy or runny nose, a feeling of fullness in the ear, or tinnitus, which I haven't got on the slide. And then when we see patients with migraine, I think this slide's important because people with migraine also get a tendency to have some rebound headache and medication overuse if they need a lot of triptans for their cluster headache. But when you get more migraine, you may see a lot of these other features. So dizziness, feeling spaced out, vertigo, tingling and twitching, feeling a bit panicky at times, sometimes a lump in the throat, blackouts, things like, you know, fainting or long fainting episodes, even hallucinations, memory problems, can't remember where you put your phone, put your milk in the cupboard and your tea in the fridge, low irritable emotional mood, restless leg symptoms, worse at night, which stop you sleeping and destroy your sleep quality, other pains, which often get labelled as fibromyalgia, neck ache across the shoulders, fatigue and weakness. If anyone wants to, I think this is worth taking down. It's just a link to the comprehensive migraine guide, and it talks about the myriad manifestations and presentations in migraine and how you manage it. And I think that can be useful. So it's www.bit.ly/migraine booklet. And if anyone doesn't get that, they can ask me later. Okay. It's also on the last slide. So on to cluster headache. I don't need to tell you this slide. It's probably the worst pain that's known to humans. There's a significant risk of significant psychiatric sequelae or problems, including the risk of suicide, which may or may not be psychiatric. It may just be that you are in incredible distress, that you don't know what to do. And if you don't know what to do, you ring the helpline. If you're in a real panic, that's why they're there. But the trouble that we have as doctors is that you might be in this state at 3 in the morning or when you're at home, but you walk into our clinic and you look great. And of course, it's just a headache, isn't it? So something that I sometimes recommend to patients, and this isn't sort of, it's probably not quite legit and appropriate, but I say, if you're really not being listened to, you can do one of two things. You can either get someone to video your attacks, which is probably the sane thing to do here. The slightly less sane thing to do is go and sit in the GP surgery, ask for an appointment urgently, go in first thing when they open. They'll say, we haven't got one. And you'll say, well, I'll just wait and see if, just sit there, have a slug of vodka or something, and wait. And I'll tell you, when you start going into an attack, usually someone will come and see you, and they'll come out to you. You don't need to go into them. So that's one way around it. It's not maybe conventional. I'll tell you what, though. doctors who see patients with cluster headache and attacks change very quickly from the person who was gatekeeping the finances of the surgery to, can I do enough for you? Actually, I don't want this patient, I'm going to send them to a neurologist urgently. You know, I want them to sort this out. How can I deal with this, you know? So cluster headache, possibly the most painful condition known, can happen at any age. It can happen in children. I went to stay with my mum last night, who's 95, and she's just coming out of a bout. She's got slight memory problems, so she said, oh, I might just have a glass of wine tonight just to see if I'm in one. And I said, well, have you not had one for a while? No, I haven't. I said, great. I said, well, I'll go and open a bottle of wine. She said, oh, there's one open in the fridge. I said, is it not gone off? And she said, oh, I think it'll be fine. In other words, she can't remember that she has a glass of wine every night, and some nights it triggers and some nights it doesn't. So that's 95, and I think certainly she was Peter Goatsby's oldest patient when she came. He's probably trumped that with someone older now. So it's more in males than females, but I don't think it's the split that we used to think of as like 90% males. I think it's just that women got diagnosed as migraine, and it's not truly equal. It is probably more in males, but I think there's a lot of misdiagnosis, as you will probably attest to. Really important features, and I think it leads us into the biology of what's going on, are the fact that it can happen on this circannual and circadian periodicity. So it can happen on a seasonal basis. Some people say it was every 4 years that I get attacks. Some people, or most people, will have a circadian change. So it will happen certain times of the day, most commonly in the early hours of the morning, but it's different for different people. It can change during the bout. The attacks are highly stereotyped. There are responses to specific therapies, and it needs its own therapies that are often very different from migraine. And therefore, it's really important to get this diagnosis right. If we don't get the diagnosis right, nothing else will flow. And that's just basic medicine. We need the diagnosis. If we've got the diagnosis, fine. And you give us the diagnosis. So you need, when you go to, and I meant to put in a couple of slides about what we want from you, but hopefully by seeing what I'm presenting today, you'll realize the sort of things that we want to know from you, particularly on the previous slide about the behavior, the duration, what time it occurs, when alcohol triggers, if it triggers. The attacks for cluster headache, I think they differ from migraine and they tend to come on quite quickly. So there's often a very abrupt onset to the attack. It's not like something suddenly hit you, but very quickly it ramps up. Now, I always feel a bit guilty talking to patients about this because I'm telling you what happens to you and I've never had it myself. But I'm going on what my patients tell me, so I'm just going on what you guys say. So typically, the attacks will last between 20 minutes and 4 hours, but that's typically, we will have patients where occasionally the attack will be shorter, or occasionally it will be much longer. We're told that it's attacks, but a third of people have background pain that's constantly there, and that may get diagnosed as different things. If it's pain that's always on the one side, and you have typical cluster attacks, then that's very typical of the 30% with cluster headache. But if you're the sort of person who has more of a bilateral pain, that might be just the price you pay for taking things like triptans, sumatriptan or zolmitriptan, which may cause rebound headache, and painkillers may cause rebound headache. And I know that there's a lot online about having Red Bull and other things, which will cause rebound headache. So a lot of those things, you might find that they help you for a short period of time, but they make it worse. So we try and limit people to the things that they really, really need in the attacks. And no one's going to forego, oh, I'm not going to take my sumatriptan because I might get a milder background headache. But for some people, that mild background headache can have all the other features of migraine, which I talked about before. So it can exacerbate your fatigue and your sleeplessness and everything else. Having said that, cluster headache on its own is enough to cause fatigue, mood disturbance, sleeplessness, and probably is going to be the bigger cause of those things than actually the rebounds from your medications. Is everyone with me so far? Yeah, okay. Cluster headache, we say it's on one side, but your bout next year could be on the other side, and it can actually alternate sides in bouts or in different bouts. Usually in a bout, it will stay on the same side, usually. It's excruciating, I don't need to tell you that. There are prominent autonomic features. So anyone that's plucked a nasal hair or an eyebrow hair know that you can get autonomic disturbance from minor traumas. Migraine can cause autonomic disturbance, but with cluster headache, it's usually really prominent. Red eyes, runny eyes, droopy eyes, puffy eyes, stuffy nose, runny nose, flushing, sweating, fullness in the ear, and tinnitus. Restlessness and agitation is a really key feature of this whole group of headache disorders, the trigeminal autonomic cephalgias. And that terminology includes hemicrania continua, which I'll come back to, paroxysmal hemicrania, and SUNCT, which I'll come back to in a minute. But all of this group are characterized by restlessness and agitation. So rather than just wanting to lie down and be still and for no one to bother you and just leave me alone to die, people will often be holding their head, they'll be often curled up rather than just lying flat and passive. They'll be pushing in really hard or worse. They might be rocking, they might want to get up, they might want to pace. They don't want to do that, they just can't help. They just don't know you don't know where to put yourself, you don't know what to do. So I think of that in terms of, you know, if you say, right, I'm going to hit you on the nail with a hammer, and I just want you to keep still, you know, you can't do that. And I think there's the same innate drive, and it's biological. It's part of your brain that's doing this, just behind the hypothalamus, that makes you agitated. So if we put, and I'm not going to do this to anyone here, if we put wires in your head for things like stimulation for Parkinson's surgery, and we stimulate just behind the hypothalamus, the area where you're having this disturbance arise, then you can actually make someone restless and agitated at that time. So there are areas of the brain where we think cluster headache is originating that does this. You can get all the premonitory and other aura features of migraine as well, because if you've got migraine biology, you're allowed to have a warning before an attack. It's not maybe as commonly noted, but things like yawning, feeling spaced out, craving food, passing more urine. 1 in 5 of you can have aura, where you get zigzags or flashy lights. Because cluster headache's often at night, people often don't recognize that aura at night because you've only woken up for the severe pain. But when people start to get attacks in the day, they may notice that. And you can have all the sensitivity to noise, light, smell, nausea, and vomiting. So what triggers an individual attack of cluster headache? And I think the biggest thing is alcohol tends to trigger within 90 minutes, whereas for migraine, it's the day after. Oh, God, last night I had 3 pints and I really feel I've paid for it. Whereas cluster headache, you don't leave the pub before you've had the attack. You know, you have your first drink, I've got to go. Volatile smells can do it. I don't think that's quite as common. I think warm environments are really key, and I'm pleased that the lecture theatre is cool today. GTN, if anyone's had angina and had a spray on their tongue, then that can trigger it. And we use that clinically. I still bring people into hospital. I can't remember the medical term for it. People call me, what's it? Paul, bastard, is that right? Yeah. So I basically bring them into hospital, and sorry if I use medical terminology that goes over your head, sorry. So I bring people into hospital, I give them 3 sprays of GTM, and I actually, if I'm not sure, I don't do this routinely, so don't worry if anyone's coming to see me, I probably won't do it. But if I really, really don't know what's happening, and I can see you go into an attack, and I trigger it with GTN, and I've got all the objective features that I can see, and then I can see what your response is to oxygen or a triptan. It gives me a lot of information in one session, and that one attack was actually very worthwhile. There may be other triggers. Some people I've seen say food. Maybe this is something for a questionnaire one day. So just because I'm aware that I've put up certain slides here, and I don't want to leave anyone else out in the room, that's for the other half that prefer men, okay? I got told off for these slides last time I gave them, and I really apologise if I cause offence, but they're just intended for humour. Because if you didn't laugh at some point, you'd be crying, so, you know. Those are the autonomic disturbances I've already talked about. I'm not going to labour those. And just look around the room, you'll see them. I've seen quite a few people with them already. So I've already talked about the frequency. Now, some people may get an attack less than once a week. For others, it may be up to 8 times a day. There's no rules in cluster headache, but it does usually occur at the same time. For most people, it occurs at the same time. And during a bout, it may start off with just 1 or 2 attacks, and then it may build up to 3 or 4 attacks, and then towards the end of the bout, it may settle back to 1 or 2 attacks. And during the bout, it may start off at 1 a.m. in the morning every morning, and then later in the bout, it's become 4 p.m. So things can change during a bout. But the commonest times are first thing, early hours, soon after you've gone to sleep, first thing on awakening, tea time, evening time. And patients feel unwell during the bout. In other words, when I use the word bout, I mean it's the duration, that 4 weeks or 8 weeks of the period when you're having the attacks, if you're an episodic sufferer. Obviously, chronic cluster headache is where you just have it and you don't get the breaks. It's just ongoing throughout the year. But that unwell during the bout, up to 30% have milder background headaches. People feel fatigued, they have poor sleep at night, depression, poor concentration, poor memory. And I don't want to underplay those because I think they may actually be the more disabling components of this, especially the depression, the despair, the poor sleep, the fatigue. It's very, very hard to continue with a normal life, even if you're having just one attack at night. To actually go to work and function in the day can be incredibly difficult. I've seen, and I'd be interested to know what Peter's seen on this, but I've seen about 3 patients now who go into psychosis when they have their actual bouts, where they actually start hallucinating and getting delusions and other things. And then when they're out of bouts, they're fine again. I don't know if it's a trigger to another mental health disorder or the stress of it's triggering something that was already there. But it's an interesting recognition. So this slide's a crunch slide in terms of have you got cluster headache or migraine. So cluster headache a bit more in men, migraine quite a lot more in women. Cluster headache, you're restless. Migraine, you want to stay still. And I went to teach people internationally and mentor them for headache disorders. And one of the Italian young consultants actually on the course, he said he used the analogy of a wounded lion, so a wounded lamb versus a sort of wounded lion. And, you know, the lamb will lie there still, migraine, and the lion will be raging. If anyone wants to ask me about the lion and toothache joke later, I'll tell them in the interval. It's a bit rude. Severity. Migraineurs have severe headache, but when they get cluster headache, they realise that cluster headache was far more severe. Autonomic features are much more featureful in cluster headache, can occur in migraine but lesser. So the attacks in cluster headache are usually less than 4 hours, whereas in migraine it will be hours to days. Alcohol immediately triggers within 90 minutes for cluster, but it's the next day for migraineurs, the undeserved hangover. I don't know why I've got a hangover. Cluster headache is side-locked, at least in 99%, but that does leave 1% who may have bilateral attacks. Migraine tends to be unilateral, but it can sometimes be both sides, or it can swap sides. But the migrainous features of the attacks, the aura, the photophobia, the phonophobia, if you've got the migraine brain, you've got those. Cluster headache bouts and who's episodic, who's chronic. So episodic is the commoner, but it's also quite common, or not necessarily quite common, but we see it quite a lot, where patients will go from episodic and then they'll go to chronic. But you can sometimes go back to episodic. So it's more common to go to chronic from episodic, but we do see people who go back again. And we talk about the bouts in episodic cluster headache occurring at a certain time of year. But I think we clearly see in chronic cluster headache sufferers that they also go through these bouts of where it's much worse. It might be through the year, but yeah, in February for 2 months it's bad, and in August it's really bad. And I don't know if it's and again, maybe this would be another good questionnaire for Ouch, but I don't know if there are effects of global warming on cluster headache, because I tend to see, and changes in weather patterns that we're seeing, I'm tending to see slight differences in when patients are presenting. We all have to sort of cater for when patients are going to go bad, and we need to do more nerve blocks and things. So we talk to the team, and I use the term cluster headache silly season for that. You know, that's where we're going to see, oh, it's February, it's whatever time, we're going to see 2 or 3 months where we're going to be really, really busy. Just very briefly, to make sure you haven't got these conditions, you're not, well, if you have, you're not necessarily sitting in the wrong place, because you can get advice from us and things. But hemicrania continua is usually thought to be a one side, and although the textbooks say it's just on one side, I think it's a one-sided predominant disorder. Personally, I think people can get a bit of headache on the other side, but it's always worse on this side, very significantly on one side, usually around the hemicranium, half of the head. They get the autonomic disturbance we talked about. They very commonly get lots of jabs and stabs, primary stabbing headaches. They get whole days where the headache is worse. They still feel a bit restless and agitated, but not to the severity and level that cluster headache patients do. and they can have migrainous features. And although this was a bit of migraine art in one of the migraine art books and things, I think this patient's got hemicrania continua, and these are the typical places that we see the sort of facial pain in a lot of headache disorders, above the eye, down the nose and down the jaw and in the teeth. But this strict laterality and this autonomic disturbance around the eye and the drooping of the face, I think this patient's got hemicrania continua. Some of the art is really quite evocative, though. So I question myself whether it's strictly unilateral. I question myself whether it has to respond to indomethacin, and while the guidance says it has to, I think we see this same clinical picture in a large group, and a small number of those respond to indomethacin. And I think that group of patients often don't respond to standard migraine treatments very well. And I think it's also a very common cause of post-traumatic headache. I've seen post-traumatic cluster headache, that's much rarer, but I think this is quite common to see this after head injuries. Oh, hold on. I'm doing something wrong. Paroxysmal hemicrania, very similar to cluster, but briefer attacks, 10 to 20 minutes, 10 to 40 times a day. And sunk sooner is this one where if you touch it, it causes pain, typically around the eye and up here. You get autonomic disturbance as well. And some people will have, this is a really good paper by Anna Cohen, but some people will have individual attacks. Some people will have lots of attacks all together, maybe around certain hours of the day. And some people will have a background period of time where they also, background period of time, and then they get these little superimposed spikes of severe pain. So how do we manage cluster headache? We want to educate patients. I think we need to educate patients so they get their diagnosis, because a lot of people sit out there not realizing they've got it. But we also want to educate patients because patients can then educate their GPs, and they can educate others around them. And you, if you have read literature from Ouch and you've been online, you will probably know as much, if not more, about cluster headache than your GP does, who maybe only sees 2 or 3 patients in their career. It's hard learning about things that you never really see very often. We want to make sure that we manage it. Can we prevent attacks, prophylactic treatment? Can we actively manage the acute attacks you've got to give you good symptomatic treatment? Sometimes we'll want to investigate you, but if I see someone who's had about 8 years ago, then about 6 years ago, then about 4 years ago, this isn't going to be a brain tumour, because it wouldn't, brain tumours don't take holidays and days off, whereas nasty pathology in the brain will generally give you a headache that's always there. And if you've got something nasty, you'll present within 2 or 3 months of that. So as soon as we're seeing people who have gone on beyond 3 months and who have no signs on examination, we breathe a sigh of relief and say, look, it's fine. Support, we need to support you, and then you need to support us to support you by doing research, further trials. So looking at the actual cluster headache itself, you can either get individual attacks, this is just a schematic of what I've said, you can get the individual attacks, or you can get individual attacks, but you've got this background of pain, so you're not coming back down to the baseline again. So you've got that background headache, and then you get the attacks on top. But those people who start off with individual attacks and gradually develop a background headache, especially if it's bilateral, it may just be a response to your medications you're using for your attacks. It may be that the sumatriptan is causing rebound. And as long as you know that, many people will say that's fine. But there may be other options to the sumatriptan. For instance, if oxygen wasn't effective, you may find a demand valve much more effective if you can get a demand valve. And I know there are issues on that, and we've got sessions on that later. How do I look at managing emergency bouts of pain? I must admit, my go-to is to do an occipital nerve block. And I don't generally just do a greater occipital nerve block. I think, from my experience, the more nerves you inject, the better the response and the longer it lasts. So I tend to do a greater and a lesser occipital nerve block. So the greater occipital nerve runs up here, the lesser occipital nerve runs up there. So I tend to inject both of those with local anaesthetic. Often we'll use steroid as well. Not everyone needs steroid for them. We can do that up to 3 or 4 times a year, generally. But doing that as soon as someone presents for maybe somewhere up to 50% will sort them out in that bout, and then they're fine. And I tend to do that. My own personal preference is for the patient to contact me a week later. If it's not worked, we'll get them back in and do the same again, and then do the preauricular nerve, which is up here, just an injection in front of the ear. And there are two nerves here, the supraorbital and supratrochlear nerves. We can do those on one needle just here. It's in-out patients. It's very easy to do. It takes about five minutes to do them, 10 minutes at most. Each injection is about 10 seconds or so. It's very, very simple. It leaves your head numb for a day. And I think it can be really effective. And that has changed my practice for what I do acutely. If I can't do those, I will generally give a reducing course of steroids, assuming you're not diabetic, and I'm not going to exacerbate that. But a lot of people get given steroids thinking, oh, this is going to sort your bout out. If we get in early with steroids, we can sort it out. Steroids don't work like that. Steroids work on the days that you have them. So as you reduce the level, or as you come off it, the headaches will come back if you're still in bout. So there's no point thinking, we're just going to give you steroids and we'll see what you're like in 3 weeks' time, because then you're back in the bout. Unless you have very short bout, if you have a bout that normally lasts 2 or 3 weeks, that might be fine for you. But if your bouts last longer, which is more common, then it's worth starting a longer-term preventative at that stage. So often things like verapamil will be started alongside the steroid. I think it's really important to give a good supply of acute attack treatments, and you may need more than one of these depending on which works quickly. So we've got oxygen, which is in the NICE guidelines for clinicians, and GPs are able to fill in a HOOF Part A form. So they are able to do that, even though they tell you they can't, because they just haven't maybe got the experience, but direct them to Ouch, and Ouch can show them what they're supposed to do. Triptans are a mainstay, so there's really very little point for most people having oral triptans because they take too long to work by the time they're absorbed. If you're going to use nasal sprays, then you don't want to be tipping your head back and sniffing, because all it does is go down the back of your throat, and then it has to get absorbed through the stomach and go through all the metabolism to get into your blood. Whereas if you just let it stay in the nose, it gets absorbed through the lining of the nose and gets in really quickly to the bloodstream. That's the whole point of it. So nasal triptans, sumatriptan or zolmitriptan, subcutaneous sumatriptan, and you should be allowed a good supply. So the NICE guidelines say you're allowed 12 milligrams of subcutaneous sumatriptan a day. So that's 4 3-milligram injectors or 2 6-milligram injectors. Most people respond to 3-milligram injectors. So try and make sure your GP will give you those. Now the trouble is they're expensive, and it's very hard without a specialist for them to suddenly commit to a few £1,000s a year on a patient. So if they're refusing you triptans, then make sure they're at least offering you the chance to be referred to a specialist who can actually say, yes, you should give the triptans. Do you see what I mean? They can't have it both ways. They can't refuse to treat you with those and also refuse to send you to a specialist. I don't think that's appropriate. Avoid the triggers where appropriate, things like alcohol. You need emotional support and information. So steroids, I've already briefly touched upon. I think these work only while taken. If they don't work when you first start taking steroids, so give it 3 days. If they haven't worked, you just stop them then. But once you've gone beyond about 5 or 6 days, you can't suddenly stop them. You have to reduce slowly because your body has stopped producing its own steroid, and then you can be very unwell if you just suddenly stop them. So if you've had them for a week and a half and you've been taking 60 milligrams, and then you suddenly stop them, you're going to be unwell. So if it's less than 3 days, or 3 days or less, and it's no effect, there's no benefit to staying on them. But if you've gone on them for at least 5 or 6 days and you're getting benefit, then keep following that course to reduce down every 3 days by 10 milligrams. And we just make sure that people haven't got diabetes. If they have got diabetes, we try not to use steroids. Occasionally we're stuck and we have to, and then you have to give some monitoring for the diabetes. Very, very, very rarely they can lead to significant mood disturbance, but I can tell you that the mood disturbance is usually there when we start giving them because of your cluster, and for 99% plus, the mood is actually better during that time. They, when used in this way, don't have any serious adverse effects on causing your hip joints to disintegrate. But if you get stuck on these or you start using these frequently, there's a very high risk that you could end up with a collapse of the hip joint. Hers quite fairly quickly. You need a hip replacement, and then you're going to be disabled when the hip replacement stops working 10, 15 years later. So acute attack treatments we use on every attack, as shown on the slide, whereas a nerve block or multiple cranial nerve blocks, we do it, and then hopefully the attacks stop, and that's it. If we're going to go down the steroids and the other an intermediate preventative like steroids and or occipital nerve blocks, and we're going to consider starting preventative. And so someone with cluster headache, for instance, who's got chronic cluster headache, we'll start with nerve blocks, and then we might go on to verapamil fairly early. Someone with a bout of cluster headache that normally lasts more than 3 weeks, we'll give them verapamil with their steroid. And as the steroid comes down, we escalate the verapamil. What you can see here is that hopefully, say you've got to here, and the steroids are almost out your system, you start getting your cluster headaches back, but the verapamil's working and it's much less severe by now. That's what we're hoping, and then we can just gradually get that down to almost gone. Having little shadows that are still there, I think, can be really useful because it can tell us we still need to be treating you. So the ideal place to get a patient with cluster headache is to get it just so we're seeing shadows, not bothering you in any way in your life, but then I know that I still need that treatment, you know that you still need to avoid the alcohol, basically. I've talked about medication overuse, and I think the main point here is it's an acceptable trade-off if your triptans are really useful in an attack. But you don't necessarily have to live with this if, for instance, oxygen works effectively, or if you get a demand valve to make oxygen more effective, that might be good enough to at least reduce your triptans down a lot. Principles of acute attack treatment: we want something that works fast in attacks, we want something that's absorbed quickly, best chance of working, easy to use, effective, well tolerated. We don't want you getting used to them and finding that they wear off. And we don't want to spend too much if we can avoid it, but sometimes we have to pay. So the main 3 acute attack treatments are oxygen, triptans, and gamma-core vagal nerve stimulation. There is a stand on gamma-core for those people who want to talk to the rep from the company later. There are some other things in the United States. They've got nasal dihydroergotamine. Very rarely we use things like octreotide. I have not really used that. Nasal lidocaine, even an antipsychotic called olanzapine, but they're not standard. And then some people will resort to Class A drugs, but if you resort to Class A drugs, then you just have a slight risk, which is not medical, but more sort of legal. Apologies for, I got told off for this slide as well, so apologies if there are any policemen in the audience. This is purely, I don't know if anyone saw The Young Ones, but I just love that episode, and it's called comedy. Okay. Because otherwise we'd cry. So, oxygen. There's going to be a talk on oxygen later, but briefly the background to it is that when we're using it, we really want it to get in as maximal as possible. We want it 100%, 12 to 15 litres per minute. Although this says sealed non-rebreathing mask, the preference would be a demand valve. If you can get a demand valve, that would be preferable because it tends to work far quicker and more effectively. So the trials in oxygen previously used standard masks. If you're using a mask without a bag on it, make sure you've taped up the holes on it, otherwise it doesn't work very well. It can take quite a long time for oxygen to work, and some people get used to oxygen. So if you're going to use oxygen, don't use it for more than 20-25 minutes an attack. Don't fall asleep with the mask on, because that just ends up leading to sort of it wearing off, and some people tell us that actually the oxygen's not effective anymore. Some people tell us they're getting more attacks. Some people tell us that when the oxygen comes off, then they get a worse attack an hour later. So if you use it short and sharp bursts, 20-25 minutes, it's far more likely to keep it fresh for the rest of your attacks and the rest of your bouts. Demand valves, a lot of reasons why they're really good. They're potentially a lot more effective. They work much quicker. They're cheaper in terms of the oxygen amounts that we give you. We don't need to give you as much oxygen. So in the long run, there's an upfront cost, but in the long run, they save money. They're safer. You're not falling asleep with your oxygen on for someone to walk in with a fag, which they shouldn't be doing, and suddenly blow up your building. They may reduce the use of triptans, and that has real cost benefits. When I give oxygen, I try and give home cylinders and portable cylinders. If you go to your GP for oxygen, they may be limited to just giving you 1 or 2 home cylinders. You can ask for oxygen in your place of work. If you're going on holiday in the UK, you can ask for oxygen to be delivered to a holiday location. So oxygen is useful if you can't have triptans, things people, for instance, with angina or heart attacks. But for some people, it may just delay the attack. Some people with respiratory problems, particularly COPD, chronic obstructive airways disease, can't necessarily have it if they retain oxygen. There are all sorts of issues on fire risks in smokers. Now, the guidance on smoking that we have in the NHS actually is guidance from the British Thoracic Society about long-term oxygen, where people are on continuous oxygen who have chest problems, who can't leave necessarily where they're sitting. That guidance doesn't specifically apply to cluster headaches, so don't be told that the guidance says you can't have it. It doesn't say that. It just means we need to be highly vigilant. Obviously, we can't be responsible for you blowing yourselves up or your neighbours, because that doesn't look very good if that happens. And it's not very nice for those people involved really either. So you've got to weigh up these things. So we just make sure that if you are having oxygen and you smoke, that no smoking should occur in the house. In that room that oxygen is kept in, and we recommend it's kept in just one room, no one should be vaping. You don't store your big tins of paint. You don't store your big jars of dermatological creams, because all those things are highly flammable. You have to really look at what the risks are and make sure that you're not having any risk there. And if you do break the rules and you say, well, I'll just have a sneaky fag, they'll find out because they come in with carbon monoxide meters, and they'll find out. But the worry is that they don't come and find out, and by then you've actually blown yourself up in your block of flats. So it's a real risk, but it's one that can be managed. One small print bit is that if you wear lots of face creams and things, they can be combustible. So we recommend, if you're using oxygen, that you don't put lots of face cream on. Okay. I'm not going to talk about that. That's more for us. But we do go through all these risk mitigation forms with patients. Triptans, and I'm going to be really brief on these, but subcutaneous sumatriptan is, I think it's the treatment of choice here. It works very quickly. If you can tolerate an auto-injector pen device, it works really well. The new auto-injectors, 3 milligram and 6 milligram, you can get, which are just a single pen that you take out the package and you give yourself. They're expensive, they're £25 per injection, but the NICE guidelines say that they're cost-effective. So expensive, but cost-effective. So if your GP is saying, I can't give you them, say that the NICE guidelines say I should be allowed up to 12 milligrams a day, and it's the CG150 guidelines. I should be allowed up to 12 milligrams a day because they're cost-effective to the NHS for me to have them. And this is a serious condition. These are clinically proven to work, and it's unethical to deny me. That's what I would put in my letters to GPs, to say that when they say we can't give them, that's what I say. Right, so they work quickly in most people, and I think about 75% or more tend to respond. They work very quickly, as I said, they're portable, they're easy. Occasionally people have side effects like chest pain. Those are the actual devices. And the 3 milligram, I think the 3 milligram works in about 80, or more than 80, about 90% of patients, as well as the 6 milligram, is less side effects. That gives you, if you're on the 3 milligram one, it gives you four attacks a day you can treat, not 2. If it's 6 milligrams, it's just 2. Obviously, if you don't respond to the 3 milligram, then use the 6. Some people find that if they've waited too long, they don't actually get as good an effect. So when you wake up in the night, I've got some patients who will, for their nighttime attacks, the 3 milligrams not good enough because they've probably been brewing a little bit before they recognize it. So I've got some patients who will have a 6 milligram at night, or they'll do 2 injections of 3 straight away, and then they'll have a 3 milligram in the day. So you need to work out what works for you. There's the nasal sprays I've already mentioned. I'm not really going to labour these. They don't work quite as effectively, but Zomig is 5 milligrams or 10 milligrams. You're supposed to have up to 15 milligrams a day. I sometimes say 20, but it's over the amount we're supposed to give. Tip your head forward, keep it forward, don't sniff in. And nasal Imogran is